Hi, my name is Dr. Amanda Briegel. I'm a citizen of Oneida Nation and a descendant of Stockbridge-Munsee Nation. This training is a part of a series developed by Native Boost. For those who may not be aware, Native Boost is a project at the Northwest Portland Area Indian Health Board dedicated to sharing accurate, high-quality childhood vaccination resources with Native people and their medical providers. To access Native Boost's education tools, you can visit www.nativehealthresources.com. Click on the Resources tab and filter resources by the Native Boost campaign. Okay, let's get started. Today, we will discuss the following: HPV at a glance, HPV-related cancers, HPV vaccination guidelines, vaccination rates, facilitators and barriers to vaccination, and additional resources for you. Let's take a few minutes to first discuss HPV. The human papillomavirus is the most common sexually transmitted infection. Nearly 14 million people newly infected each year. According to the World Health Organization, there are approximately 14 different types of high-risk HPV that are associated with cancer. Transmission occurs through sexual contact and touch, including oral sex, anal sex, and vaginal sex. Cervical cancer is almost always caused by the HPV infection. Cancers of the oropharynx, anus, cervix, vagina, and vulva have been attributed to high-risk HPV infection. Next, we're going to briefly delve into the HPV-related cancers. This figure shows the number and type of HPV-related cancers in the United States. As you can see on the left, these are the total population and HPV-associated cancers. Across the U.S. population, you can see the most common type of HPV-related cancer is oropharynx. And then if you look at it by men and women, the most common HPV-associated cancer among men is oropharyngeal. This is the back of the throat, the tonsillar area. And among women, it is cervical cancer. Now I'd like to discuss some information related to HPV vaccination guidelines. For individuals ages 9 to 14, when they start the vaccine series, they require only 2 doses of the vaccine to be considered fully vaccinated. This is when they start. So if someone starts at age 14 and then turns 15 while they are waiting the next dose in their series, they still only need 2 to be considered complete. This includes all healthy individuals ages 9 to 14. For individuals who are immune compromised, for example, they're on chronic steroids or they're immune suppressed for some other reason, they would require 3 to be considered fully vaccinated. For individuals ages 15 to 26, a total of 3 vaccines is needed to be considered fully vaccinated. So starting at age 15 and older, they need 3 vaccines. We'll talk briefly about HPV vaccination rates. Here is some data from a joint project between myself and the Northwest Portland Area Indian Health Board Tribal Epidemiology Center. We looked at the rates of HPV vaccination initiation, or starting the series, here in the Pacific Northwest. The dotted line shows you the 2020 national estimate for individuals aged 13 to 17, just for a reference. The colors in orange are for individuals assigned female at birth. As you can see for all ages across both genders, that the rates of HPV vaccination initiation has been increasing since the beginning of our study period in 2011. Females outnumber the males, which is a trend that is common throughout the United States in both the native and non-native population. The ages most likely to start the vaccine series are those between the ages of 13 and 18. Those least likely to start the series are those between 9 and 12. This slide shows you information on the series completion. We know that nationwide that the rates of completion lag behind those of initiation, so that those who start the series do not always complete it. The dashed line at the top shows you the Healthy People 2030 goal, which is to achieve 80% of our population having completed the vaccine series. The CDC national estimate for ages 13 to 17 is also a dotted line below, which is at 58%. Again, you can see in our trends, so people assigned female at birth are in the orange-red colors. The age most likely to be finishing their vaccine series are individuals in the 13 to 18 age group. And males, once again, lag behind females in completing the series. So facilitators and barriers to HPV vaccination. Factors associated with higher rates of HPV vaccination are provider knowledge. If a provider is able to provide well understood education and knowledge around the HPV vaccine, its safety, when to use it, and its efficacy, this has been associated with higher rates of trust and higher rates of uptake among patients. And this is also found to be particularly true in the Native population. Some of the barriers to HPV vaccination specific to our population, the Native population. So safety. A number of the articles published from our communities showed that there's a concern of safety of the vaccine in about 46% of people who had been surveyed. And again, knowledge of the parent, the caregiver, or the recipient. Not having sufficient knowledge and awareness about what the vaccine was for and what sort of protection it provided was negatively associated with HPV vaccination. And then for some parents, there's concerns about sexual activity. This occurred in about 1/3 of papers specific to the Native population and why they did not access or accept HPV vaccination. So something important to tell your communities, your health partners, your patients is that HPV vaccination is cancer prevention. So things that you can have your community walk away with after you talk to them are some of these elevator pitch talking points. First, the HPV vaccine prevents nearly 100% of cases of genital warts. Though these won't cause cancer, this is a sexually transmitted infection that can be fully prevented through vaccination. And the HPV vaccine prevents cervical cancer as well as cancers of the vulva, vagina, mouth, throat, and penis. And it's more effective in preteens. So individuals aged 9 to 12 have a robust immune system that responds well to this vaccine. And individuals at this age are also less likely to have been exposed to the virus previously. And so by providing them an early vaccination, their immune system is ready to accept it, and they're less likely to already have been exposed to HPV. The earlier a child is given the HPV vaccine, the sooner they will be protected from these 6 different types of cancers. And one of the beautiful things about this, and another thing to communicate with your population, with your community, is that this is long-lasting. So it is safe, it is effective, it is long-lasting. Concerns about sexual activity have been consistent among parents and caregivers since 2006, when the FDA first approved the vaccine for females ages 9 and above. And it's been very difficult to dissociate the sexual marketing. So when it was first marketed, it was really targeted towards young women and sexual activity and cervical cancer, and it's been hard to unwrap this. And there have been many studies done looking at sexual activity rates among those who choose to accept the vaccine and those who don't. And so to be clear, something to tell parents and caregivers that are concerned, there is no published data to indicate that this increases activity, sexual activity. Many clinical offices will bundle this vaccine with the tetanus and meningococcal vaccine at ages 11 to 12. Which is a great strategy when you're trying to market this to a parent. Your child is due for A, B, and C. Any questions about the vaccines they'll receive today? And what often happens in this age is that children start to go through puberty. And with puberty comes sexual curiosity and awareness. And so some caregivers and parents have incorrectly linked these two together as a causal relationship. And so it's just important to really confidently let your patients know there is no data to support this. It has not been shown in any study to increase sexual activity. And now for some additional resources available to you for increasing the rates of HPV vaccination. There's the HPV series Quality Improvement Project. This is from the California American Academy of Pediatrics. Some of the material that they recommend that you do to increase rates is to provide brochures to 9 and 10-year-olds. Start to plant the garden. You might not start the vaccine series in your clinic until age 11, but you can plant the seeds at the well child visit. Your son, daughter, niece, nephew, they are going to be eligible for this in the upcoming years. Here's some information for you. We can talk to you more about it at your next visit. Plant the seeds to help them think about things and ask questions so that by the time they are 11, if that's when your clinic chooses to start the vaccination, they're ready. Create a roster of 10 to 12-year-olds who have not made it in for a physical, having a navigator track these patients who are due and could be eligible at their next visit. And then look up patients turning 11 and call them to come in for an appointment. Patient reminders are so very helpful. There's busy lives, there's back to school reminders, and things of that nature can be incredibly powerful for just helping people to get in and get their vaccine. Additionally, as part of a clinic practice, make each patient's immunization record available at the beginning of the visit. And so just having that be part of your routine for well child exams, reviewing that material briefly, letting the parent or caregiver or child know you're due for these things today, what else do you want to talk to, and just make that part of the standard script for your visits. Summer camp or sports physical forums, it's an opportunity again to just look at the immunization records and recommend the HPV vaccine if that has not already been given. Some things that can be done at the clinic level. Consider adopting tribal clinic standing orders for HPV vaccinations. If you can take some of the red tape from order entry to getting the vaccine in the arm and removing that, that is a clinic level barrier that can just be removed for efficiency. And so if there are standing orders and nursing staff can give the vaccine based on these, that is just one quick, easy way where it's not a physician or advanced practice provider reliant order that needs to be written. You can just take them out of it by adopting some standing orders. It's really, really helpful and important for the whole clinic to be on board. So medical assistants, schedulers, nursing staff, other members of the team. If everyone is on board and confident and educated around this, whoever the patient and their family look to for affirmation about this information, they can receive the same consistent positive message. If a patient comes in due to illness, but you notice that they are due for their vaccine, take it as an opportunity of, okay, we're going to treat your son, daughter for strep throat, take these antibiotics, and I see that you're due for the HPV vaccine. Let's get you an appointment in a few weeks when you feel better and get you up to date. Just taking an opportunity of every visit to see if we can help increase these vaccination numbers can be incredibly helpful at the clinic level. Some of the messaging to caregivers and patients, and this really does need to be adapted to your local culture, your local regional context. For example, in some areas where I practice, the word vaccination is met with a lot of resistance, but immunization is considered more welcomed. And so making sure that whatever information I give you today is actually tailored. So some of the things that you can do if it aligns with your regional and clinical values are mentioning the HPV first and not last. So today we're vaccinating against HPV, tetanus, and Tdap. Do you have any questions about this? And also providing parents with the proof of the long-term studies. So pamphlets and handouts can be helpful, particularly if someone says no or they're hesitant and you want them to come back and review things. But really the most powerful thing is for a provider to powerfully and confidently recommend. I highly support this vaccine. I would do this for my own children, grandchildren, nieces, or nephews. I can't give this strong enough endorsement. And saying that and meaning that is the most powerful intervention you can do. And so providing the information for people who are hesitant or have questions to allow them time to review and come back to you, those can be incredibly powerful. The FDA supports the HPV vaccine because it's most effective when given to adolescents before they're ever exposed to HPV. And that is the rationale for the young ages that we recommend in this 9 to 12 arena. Their immune systems are well poised to respond appropriately to this vaccine. It's effective giving it 9, 10, 11, well before they're exposed to HPV in most cases. And when a patient or a parent or a caregiver chooses to proceed with the series, you can congratulate them for prioritizing their health and to make them feel good about a great decision for their own wellness. There are different strategies to use when you have a vaccine-hesitant parent. The first thing that I like to do in clinical practice is to acknowledge that it's okay to have questions and that I am here to provide objective, well-vetted information on their behalf, and that I know they love their child, they care for their personal wellness if the patient is making their own decision, but to really create a foundation of shared support. We both care about this young one, and we want to make good decisions based on their well-being first. And I think it's really important that you feel comfortable with the decision you make. And sometimes that's all you need to do with that first visit. And it'll take 3, 4 visits to continue to have this conversation for them to feel like they can talk to you. But I think the first thing you can do is acknowledge and create some sort of foundational framework that is shared. Providing information, the CDC handout is great. There are other resources that are out there and available, potentially through local cancer institutes or other vetted resources. And you can also use in vignettes. So for example, the CDC has a vignette written by a father whose daughter had cervical cancer at age 23. Sometimes stories like that can be really powerful. So you have to have kind of an ear to the ground and a way to understand your patient population and this particular family and kind of adjust and tailor accordingly. But I think the first thing you can do is acknowledge and respect that hesitancy so that a door doesn't get shut. And just start to plant the seeds for a garden that might grow something in a couple visits. In addition, you can also ask them to do their own homework. You can give them some resources. You can ask them what they're reading. There's so many different things on social media right now that some are vetted, some are not vetted, and really gaining an understanding of where the information is coming from and providing some support and feedback around the sources. So it might be not at that visit that you change their mind, but perhaps you can change how they search and who they look to. And so providing good resources that they can start to investigate themselves. Messaging to youth is also very important. So one of the best things that is available right now is to emphasize that it's a cancer prevention vaccine, making it less about HPV and the sexual transmission of the virus and more about this vaccine can prevent 6 different types of cancer. Talking about it through several arenas and several times. If the nurse mentions it during grooming, your son, daughter, niece, nephew, grandbaby is eligible for A, B, and C vaccines today. The provider will talk to you more about it, handing them the information at the start of the visit, discussing it at the end of the visit. So having a couple different touch points throughout the visit to really mark its importance as a healthcare promotion tool, and also so that they understand that the whole clinic is involved and on board with this. And it's also important during educational moments with the family to explain that sex isn't the only transmission route. Sexual touch is also an HPV transmission route. So even if youth are not sexually active fully yet with sexual intercourse, sexual exploration and sexual activity can still lead to transmission of the virus. We do have an HPV vaccination as cancer prevention toolkit that's available. It is a resource guide for providers of American Indian and Alaska Native patients to prevent HPV and HPV-related cancers. It's been developed by the Knight Cancer Institute and the Northwest Portland Area Indian Health Board. It's been updated to include a number of different topic areas, some tips and tricks for increasing vaccination in the Native population, and also some additional information that we didn't cover today. The American Indian Cancer Foundation is another excellent resource for information. It has, it's at americanindiancancer.org, and they have a number of patient education tools. They have it through social media, Facebook Live with their lightning webinars, as well as things that can be ordered for the clinic with infographics and information that are pertinent to our communities, and also other more supportive materials that are available. Native Boost is also a great resource. To access Native Boost patient education tools, you can visit www.nativehealthresources.com. Click on the Resources tab and filter resources by the Native Boost campaign. Let's take just a few more minutes to discuss HPV. This is a graphic provided by the CDC, which is a really good stepwise thing to consider implementing in your clinic if you do not have these things already in place. I encourage you to review what is existing in your clinic and to see how you might adapt this framework to meet the needs of your unique clinic culture and clinic population. First and foremost, learning. Making sure you understand yourselves as providers about HPV vaccination, HPV, HPV-related cancers, so that you can fully seem confident and knowledgeable to your patient population. We've talked about how the provider voice and provider recommendation is one of the most important things that you can do, and this is where it begins. We start with the knowledge that we ourselves are confident, and then we make sure that our whole clinic team, this is the informed part, making sure our whole clinic team understands this is the messaging and this is the value system of our clinic, and to make sure that everyone else who is at a patient care touch point also has this information and can feel confident about asking questions. After the clinic team and the individual has the knowledge they need to impart this to our patient, then we start to go outward with our intervention. We need to communicate, whether that's infographics, whether that's social media, whether it's brochures. Communicating this message frequently and through a diverse portfolio of ways is very powerful and important to making sure that patients have the education they need to understand that HPV vaccination is cancer prevention and that they can participate. Next, it's important that we recommend it. We can't wait for our patients to come to us and say, oh, hey, what am I due for? Most people don't come and ask us for a shot, right? And so finding a strategy for how best to recommend the vaccine in our clinics, whether it's planting the seeds and just providing some education starting at age 9, whether it's taking the bundling approach at age 11, where you wrap it up with the Tdap and the meningococcal vaccines that are also recommended at that age. Finding a strategy, making sure you activate it for all patients. And then when someone is in the vaccination mode, making sure that you vaccinate them, follow-up phone calls and reminders to get those second and or third vaccines in so that they can be vaccinated. Here are some references for your resources. And thank you so much for your time and attention today.